Good morning, everyone, and welcome to this session on LGBTQ plus health. My name is Dr. Kit Tigwell. I'm a GP and I'm also co-chair of GLAD, which is the UK's Association of LGBTQ plus doctors and dentists. Delighted that you can join me either live this morning or if you're watching on catch up. What we're going to be doing this morning is celebrating LGBT History Month, which is celebrated every year or has been every year for the last 20 years or so in February. And there's a theme every year. The theme this year is medicine and healthcare. So what we'll be doing is taking a brief look back at the history of LGBTQ plus health in the UK, which has had several crises in it and has quite a lot of matters of conscience as well, and thinking about what sort of society we want to live in. We'll think about the journey of LGBTQ plus doctors in that as well, and how life has changed for them, and think about what history tells us about the health issues that are faced by the LGBTQ plus community today, and also where we want to go next with improving the health and the lives of LGBTQ plus people. So there's quite a lot to cover. We'll whiz through it, and I think there's the opportunity for you to get involved as well, either by asking some questions here or by using this Slido, where if you go to that website there, slido.com, and join with the code on the screen, you'll be able to ask questions, which we can come to at the end. You can also scan that QR code, which will take you to the same place. Just a bit of a content warning about some things that we'll talk about this morning. There will be mention of mental health problems, including suicide, domestic abuse, and also some medical procedures, which some people might find upsetting. Nothing too dramatic, but just to let you know that that might come up if that's something you're not comfortable with. So, kicking it off then, this is a quote from a study that was done into the experiences of gay men in the NHS over the last 50 years or so. And I think this quote summarises really well some of the problems that have LGBTQ plus people have faced when they're going to see their doctor, and some of the attitudes that they've been faced with. So how did we end up getting to a stage where that was the attitude that doctors had when people came to see them? Well, we have to go back a little bit further to the partial decriminalisation of homosexuality in 1967. And this came about off the back of a report by the government called the Wolfenden Report, which in 1957 looked at prostitution and homosexuality and whether it was still appropriate to criminalise those things in law based off a number of high-profile court cases that had happened and scandals that had happened involving sort of fairly well-known people. And that report recommended that homosexuality between men be decriminalised. But it wasn't a full decriminalisation, so it only permitted sex between men over the age of 21, and only if there were only two of you in the house. So if you had a housemate and they were home as well, then you'd be breaking the law. And only in certain settings. So it wasn't decriminalised in the military until 1994, not in Scotland until 1981, and Northern Ireland a little bit later. So actually, although there's this change in the law that everybody holds up as being the start of LGBTQ plus rights, it was only a partial change in the law. And actually, the number of convictions and arrests for being LGBTQ plus or engaging in homosexuality actually went up after the law changed, because the police were a lot more hot on it and looking out for it. It's interesting to note that homosexuality between women has never been a criminal offence, simply because people thought it wasn't physically possible. So we were only talking about men here. In 1965, so a couple of years before the law was changed, there was an opinion poll of the UK population, general public, in which 93% thought homosexuality was an illness that required treatment. So that's the sort of social environment in which people were existing at that time. And that's also reflected in how the medical profession viewed homosexuality. So the DSM is the Diagnostic Manual of Mental Health Illnesses, and the ICD is the International Classification of Diseases. And these are both documents that are produced internationally by the medical community, and they list what's a disease and what isn't, essentially. And homosexuality was classified as a mental health disorder in these manuals, in these documents, until 1990. So quite recently, really. And even in the United States, having a different sexual orientation other than being straight was classified as a medical disorder in 2013. So the idea being that if it's classified as a disorder, that means there must be some sort of treatment possible. And as we'll come on to explore, that sort of informed a lot of how healthcare services have been set up around LGBTQ plus people. So anyone in the 1980s and 1990s, before it was declassified as a mental health illness, often the first thing that happened to them if they came out to friends or family is they were taken to see their doctor. And they were taken to see if there was anything wrong with them, and whether they needed any sort of treatment. And the way that people used to decide whether there was anything wrong with them or not were based on quite sometimes invasive and distressing tests, which had no sort of scientific basis at all. For instance, there's talk of people going along to see their GP, and the GP saying, well, you can't be gay because your wrists aren't limp enough. So things like that, which are just completely pseudoscientific and ridiculous. But that sort of approach of it being a mental health problem, that path paved the way for treatments on the NHS to try and manage homosexuality. And those are things like aversion therapy. So what used to happen to people is they went along to the local NHS hospital, and then they were either given a medication to make them feel sick, or they were given electric shocks, mild electric shocks, while looking at some kind of homoerotic stimulus, photo of two people engaging in same-sex acts, for instance, something like that. And the idea was that while you were looking at those things that you would find attractive, you were given an unpleasant stimulus, an electric shock, or made to feel sick, and that would put you off finding those things attractive. It's the sort of thing that people do with dogs and rats in clinical studies sometimes. It's completely ridiculous. It doesn't work. And sometimes people underwent these treatments for years. Another example of this is Alan Turing, who you may know as the code breaker from the Second World War, a computer scientist who was a huge part of the war effort, but was also gay and was prosecuted for that in the 1950s. He was given the choice of either going to prison or being made to take estrogen hormone therapy, which essentially rendered him infertile. And that was because people believed that if you were homosexual, you shouldn't really be able to reproduce. So that's another example of some treatment that was sanctioned by the state and by the health services for homosexual people. Now, obviously, that doesn't happen, but there are other practices, sometimes more severe things, both physical and psychological, that are done to LGBTQ plus people by religious and cultural groups, and sometimes even still by healthcare professionals in this country and around the world, which are classed as conversion therapy. So any effort to try and change somebody's sexual orientation or gender identity through those sorts of means. It's completely, has no scientific basis. It doesn't work. There's nothing to cure, but still it's offered today. And there's some ongoing work at the moment by the government to try and ban the last of those dangerous practices that are still out there. So that was all going on in the 1960s and 1970s. And then in the 1980s, of course, along came HIV and the AIDS crisis, which really characterizes the landscape for LGBTQ plus people still to this day. When that crisis arrived, there was a lot of stigma in society against LGBTQ plus people. There was a lot of stigma in government and amongst authorities. And generally, health authorities didn't really act or do anything about it. It took several years for any kind of health authority to take any sort of official action to try and address HIV or find out more information about it. In fact, the Royal College of Physicians didn't officially discuss HIV for 6 years after the epidemic started. So that's 6 years of the community being ignored and not having any treatment or interest showed to them. And in fact, AIDS, the original name for AIDS was GRID, which stands for gay-related immune deficiency. So it was originally badged as a gay illness that only affected gay people, which of course we know isn't true, but the hangover effects of that approach are still seen today. And people still think that LGBTQ plus health today is only about HIV and sexual health. And in reality, it's about so much more than that. So we need to start moving away from those stereotypes, and we'll think a little bit about how that can be done a little bit later on. And then the last point on this slide is thinking about equality legislation. So this started sort of in the 1990s, late 1990s, early 2000s, when the first legal protections for LGBTQ plus people came in, which is, anything from things like provision of services, so not being discriminated against if you go to the shops or go and contract the services, if you're accessing housing, but also if you're accessing healthcare as well. So it's really only been in the last 20 years or so that there have been legal protections for LGBTQ plus people and their health. So that was LGBT people quite generally, and now what about transgender history? Now, I think this is really interesting to understand a little bit more about where we are now with transgender health and transgender rights. And there's an awful lot in the media, an awful lot of discussion and debate, and sometimes quite polarized conversation about transgender people at the moment. And actually, if we understand more about the history, we can start to pick that apart and understand really what's been going on. So the awareness of the Western world here in the UK, we've started to become more aware of transgender people and gender diversity over the last few years, really, and it seems to perhaps come out of nowhere a little bit and something that was a bit new and we're a bit uncertain about. But actually, there's been evidence of people who don't fit into gender norms of being either entirely male or entirely female for a long time, all the way back to prehistoric times. We think there's evidence of people who haven't had a gender or people who've had a third gender, and the ancient Greeks famously had a very different attitude to sexuality and gender than we do, and even the ancient Romans, there's evidence of people who we would now probably consider to be transgender back in ancient Roman times as well. And it's also very culturally dependent. So we in the UK and the West have a very specific idea of what sex and gender is, but actually in other countries and other cultures, they have different ideas. So in Indian and Arabic cultures have a long tradition of third genders, as do religions like Hinduism, Jainism, and Buddhism as well. So trans people have been around throughout the entirety of history, but in the Western world, we really start to come across them at the turn of the last century, so the early 1900s. The first diagnostic criteria, so the first attempts made to diagnose what being transgender were made in 1886. And it was classified as what's known as an intersex disorder. So people were born with physical characteristics which didn't match their internal sense of their gender and who they were, and that was known as being intersex. And because that was a physical disorder, people thought, then they tried to offer physical treatments for it. And the first criteria, as I say, were drawn up in 1886, with surgical treatments and hormone treatments being offered from the early 1900s, around 1919, that sort of time. In the 1930s, one of the first well-known trans people was Lily Elbe, who was a trans woman. She was the first person to undergo documented sex reassignment surgery in Europe, which unfortunately she died of complications from. But you may know her because of the film The Danish Girl, which was made about her life. A little bit closer to home, Matthew Dillon was a trans man who lived in Bristol. He had hormone therapy in 1939, subsequently went on to have surgery, and also he changed the gender on his birth certificate in 1944, and after which he went on to become a doctor. So that's one of the first examples in the UK of a transgender person having medical care. In the 1960s, 1950s, 1960s, Ewan Forbes, or Sir Ewan Forbes, was a trans man and a GP in Scotland who had hormone therapy in Europe in the 1930s, changed the gender on his birth certificate in 1952. And interestingly, all his patients at the time were reported to be very supportive of him. But his case is very interesting because you'll notice that before the 1960s, there's all these people who are changing their gender on their birth certificates. They're undergoing treatment to affirm their gender, and obviously, I've only picked a few examples here, but there were many more people who were doing it. But that's quite different to the landscape that exists for trans people today. So medical care is much harder to access for them. They have to go through many sort of legal hoops in order to change their birth certificate, and it seems to be much more of a controversial thing. So something changed in the 1960s from people having legal equality and equal rights and finding it easy to do this, or more easy perhaps than today, and how things are now. And what changed was Ewan Forbes, and he was from an aristocratic family in Scotland. And when his father died, he came up to inherit the estate and the title. But the law says, even now today, that some estates and titles can only be passed down the male line, so from father to son. And because Ewan was born as a woman, assigned female at birth, his family contested that he couldn't inherit, even though he had transitioned to male. And there was a long legal case, which ultimately he won. But both that and the case of April Ashley, who was a famous model in the 1960s, who was a trans woman, those legal cases drew the attention of the legal system to trans people. And as a result of the April Ashley case, there was a new definition of sex and gender that was brought in by the judge in that case, who essentially decided that he didn't like that transgender people were classified as an intersex disorder. He thought it was a mental health problem. So he changed the legal classification to a mental health disorder. And this wasn't based on any medical evidence. It wasn't based on any science. It was just based on one judge and his opinion. And the sort of the criteria that he used to draw up and say, well, this is what we think sex and gender are now, was completely made up. It's things like, what do your genitalia look like? He even did things like measure the depth of people's vaginas to try and decide how deep it had to be for you to be considered a woman. So it was all complete made up nonsense. But that became then the legal definition of being transgender. And what that did is, by classifying it as a mental health problem, it opened up the avenues for medical treatment and mental health treatment based on that assumption. So the first gender identity clinic, so the first health clinic for transgender people, opened in the UK in the late 1960s. And the treatment that they offered was based very much around it being a mental health problem. So you saw a psychiatrist, and you essentially had to be compliant with their plan. So if they thought that you weren't masculine enough, you weren't feminine enough, you weren't committed enough to their treatment, then they discharged you and you didn't get any medical care at all. Ultimately, as I alluded to with Alan Turing, people felt that, or the prevailing thought in the medical community was that transgender people shouldn't be allowed to reproduce. And part of the treatment that was mandatory and compulsory in the first gender identity clinic was sterilisation. So the really quite unpleasant and unethical things that were going on. And the result of all of this was that transgender people were completely socially ostracized and alienated, and often avoided any sort of contact with the state or officials or the police, simply because they would be persecuted and sort of treated as a mentally ill lesbian or a gay person instead of a transgender person. So not a particularly happy time over the second half of the last century. And until 1993, it was perfectly legal to discriminate against transgender people because of their gender identity. so long as you discriminated against them all equally. So if you said, I'm going to fire one trans person from my organisation, that would be unlawful. But if you said, I'm going to fire all of them, then that would be perfectly okay in the eyes of the law. And that was only changed in 1993, after which more laws and legal protections came in for gender identity, which was sort of culminated in the 2010 Equality Act. So what's really interesting about this, I think, is to imagine that you are an older transgender person, now in your 60s, 70s, 80s. You will have lived through all of this, and all of your experiences with healthcare when you were younger would have been through that lens of people assuming you were mentally ill, being forced to have treatments against your will, and now older people who come to access healthcare in their later life, sometimes at the end of their lives, so palliative care, come into it with all of that experience and that fear. So there's a lot of examples of older transgender people fearing that they will not be allowed to continue their hormone therapy when they're older, not being allowed to wear the clothes that they want, worried that their carers will not want to look after them or give them personal care, worried that they'll be misgendered or called the wrong name at their funeral. And all of these things have happened. So it's a real problem in that how can we now start to reassure people that attitudes have changed to some extent, and the medical community is actually there to look after them, given all of their previous experiences. So there's been a slow change. I won't call it a steady progress, because we seem to have gone backwards in the 1960s, and only now we're starting to reinstate some of the legal protections that were lost. But society has changed. And in 2020, there was a survey done that showed that 84% of UK population felt they were not prejudiced against trans people. But that doesn't seem to be particularly well reflected in the tone of the media conversation today. And even in countries like the US, we're seeing that legal protections for LGBTQ plus people have started to be reversed and rolled back. So just because there has been some progress doesn't mean that we can take it for granted that there will continue to be progress. Having said that, there's been some more surveys over the last few years from the UK and the United States of Generation Z, sort of aged under 25 at the moment, who say that almost half of them are not exclusively attracted to the opposite sex. And just over a third of them know somebody who's using they or them pronouns, or whose gender identity doesn't necessarily match the sex they were assigned at birth. So amongst the younger generation, there are things that are continuing to change, and there's an appetite for further change in the future. So having thought a little bit then about the experience of patients, what about the experiences of practitioners and LGBTQ plus doctors and dentists? So the first society which aimed to support and organise LGBTQ plus doctors and dentists was founded in 1975 in London, and they did things like campaign in medical schools for better support for students and doctors. They went on gay rights marches. They provided information leaflets on homosexuality to doctors and GPs across London, and they attended meetings of medical organisations which were usually hostile to them and declared that they were homosexual, and actually they weren't so bad after all. In the 1980s, that evolved into a more formal organisation, the Lesbian and Gay Medical Association, and they were instrumental really in providing healthcare and changing the health conversation around HIV and AIDS. So as I said, the authorities really didn't act very quickly at all about HIV and AIDS. So the Lesbian and Gay Association produced the first information leaflet on AIDS in Britain. They organised the first conference on AIDS alongside the Terence Higgins Trust. And they also organised the first international conference on homosexuality in medicine in 1986 as well. So there's lots of other examples alongside that of individuals taking it into their own hands to provide information and support to LGBTQ plus people about their health, because there was no one else doing it and no one else to step in. In the 1990s, the association evolved into GLAD, which is the organisation that still exists today. And the aim of GLAD was to become more inclusive, so doing more for women, doing more for gender diverse people, and being more mainstream as well. So trying to move from this sort of peripheral field of activism and being sort of a bit out on your own, waving your flag, to come into the mainstream of the medical establishment to try and change things there. So they did things like produce guidance on equality in the workplace, and worked with people like the General Medical Council to improve the lives of LGBTQ plus doctors. But despite all that, there's still much further to go, as we'll come on to talk about a little bit later. Now, this being History Month, I thought it'd be nice to highlight a few key historical figures from LGBTQ plus medical history. And there's obviously loads more that I could have chosen, but these are some of the key ones that I thought were interesting. The first one of whom is Sophia Jex-Blake, who was the first woman to qualify as a doctor in Scotland. She was a couple of years behind the first woman to qualify as a doctor in the UK, who was Elizabeth Garrett Anderson. But the difference was that Sophia Jex-Blake was the first woman to ever go to a medical school. She campaigned as part of a group of women known as the Edinburgh Seven to be allowed to attend medical school in Edinburgh. And she was successful in doing that, qualifying in the 1860s, and was one of the first women to attend a British university. She lived with her life partner, Dr. Margaret Todd, and her campaigned throughout her career to establish medical schools for women in Edinburgh and London. And she also led to a change in the law allowing men and women to be granted a license to practice medicine, whereas previously it was just men who were allowed to do it. The second person I've chosen to highlight is an American doctor called Alan Hart. He was a transgender man, the first trans man to undergo a hysterectomy or a removal of his womb in America in 1917. And his contribution to the field of medicine was he was a pioneer in developing X-rays to detect TB or tuberculosis. Before that, people could only diagnose it based on someone's symptoms, whereas actually he discovered that you can use X-rays to see the infection in the lungs much earlier than the symptoms develop. So that was a great leap forward in the treatment of that condition. Because he was a trans man, he often, unfortunately, found that throughout his career, despite being very accomplished, he had to keep moving around the country, because as soon as anyone found out about his gender identity, he was forced to resign from his job and leave. And the final person I've chosen to highlight is someone from slightly more recent history, Mags Portman, who was a GP and a HIV consultant in London, who sadly died in 2019 from cancer. But she was instrumental in getting a medication called PrEP to be available on the NHS. And PrEP stands for pre-exposure prophylaxis. And essentially, it's a medication that you can take either once a day or as and when required that prevents you catching HIV through having sex. So as you can imagine, this has completely changed the landscape of sexual health for LGBTQ plus people and has dramatically reduced the number of new HIV infections from sex that we have seen in the UK. And through that has saved many thousands of lives. We'll never be able to put a figure on it. But prior to 2020, this medication wasn't available on the NHS. So a lot of what Mags's work was about was researching it, developing guidelines on how to use it, and campaigning for it to be introduced on the NHS. She also tested the safety of medications that people were buying online. So before this was available on the NHS, people used to go online and buy it from abroad, which is completely unregulated. You don't know what you're buying. You don't know if it's going to be safe. You don't know if it's going to have any of the actual medicine in it. So she did a lot of safety testing around that as well. So as well as really important work, the thing I like about Mags particularly is that she was an ally. So she wasn't a member of the LGBTQ plus community, but she's an example really of what can be achieved by people engaging with the LGBTQ plus community to understand their health needs and then standing up for what they believe to be right. So Having thought a little bit then about some of her work and more recent history, what are the current issues facing LGBTQ plus people and their health? Well, the big problem is that there's a lot of what we call health inequalities. What health inequality is looking at measures of people's health. So, that could be things like their mental health, or looking at their risk of physical health problems, maybe like heart attacks and strokes and cancers. And what we see is that in minority groups, people who are part of a minority group have worse health than the general population. And that comes about as a result of difficulties in the way society is set up. So distribution of power and wealth in society, access to good quality housing, access to healthy food, access to green spaces, quality of education. There's lots of things that feed into it. And we, as we'll come on to see, LGBTQ plus people, unfortunately, do have poorer health than the general population. And perhaps having understood a bit of the history, we can start to understand why that might be the case. Access to transgender care for transgender people, I've sort of alluded to already. That's a big problem at the moment, in that people don't have the access to care that they need in a timely way, and we'll come on to explore that a little bit more. So-called conversion therapy, as I said right at the beginning, that still exists at the moment, and there's ongoing work to ban that. And as I said, despite the work of those LGBTQ plus practitioners and doctors through the last 50 years or so, actually it's still not very easy to be an LGBTQ plus person working in the health service sometimes. So we'll explore some of those issues. And I think it's interesting to reflect that actually there are quite a lot of LGBTQ plus people out there, about 3 to 6% of the population, up to 8% of under 25s, and about 0.5 to 1% of the population are transgender or gender diverse in some way. We don't quite know the true figures, but that's as best an estimate as we have at the moment. To compare that, the number of people who've got rheumatoid arthritis is about 1% of the population. And we know a huge amount in the medical profession about rheumatoid arthritis. We know what causes it, we know how to treat it. There's new research going on all the time to develop new treatments. There's charities about it. There's lots of public awareness about it. And actually, there's perhaps just as many transgender people as there are people with rheumatoid arthritis. And we know so much less about medical care for that group of people, and there are many fewer services set up to help them. So there are a lot more people out there than we perhaps realize who are deserving of high quality medical care and aren't getting it at the moment. So health inequalities then, what sort of things are we talking about? So there's not a huge amount of evidence about this, simply because the academic community, the research community historically has been biased against doing any sort of research in this area. It's not something that was thought to be suitable. So only more recently are we starting to get data about this, and much more needs to be done to understand why these health inequalities come about, and more importantly, what we can do about them. But what we do know is that LGBTQ plus people are more likely to have poor mental health, eating disorders. They're more likely to misuse alcohol or drugs or smoke, more likely to become homeless, and less likely to engage with health services as well. So there's lots of things that are going on here. And what we know is that the distribution of those inequalities within the LGBTQ plus community is not uniform. So some people are more likely to have problems than others, even within the community. For example, bisexual people tend to have worse mental health than lesbian and gay people. Lesbian and bisexual women are twice as likely never to have had a cervical smear, so screening for cervical cancer, than other women. So they're less taking up that less, and therefore are more likely to be diagnosed with cervical cancer. And 70% of bisexual women have anxiety, compared to about 53% of gay men. So there's lots of things that are going on that we don't really fully understand yet. And the other thing about health inequalities is that the more minority characteristics you have, the more likely you are to have disadvantage. So LGBTQ plus people who aren't white are more likely to have an eating disorder than white LGBTQ plus people, and twice as many disabled LGBTQ plus people self-harm compared to non-disabled LGBTQ plus people. So there's, again, much more that needs to be done to understand what's going on there and really tackle and target services for the most vulnerable people who are having the worst health outcomes. At the moment, it's very difficult to target services to those people because, as I said, we don't know enough about it, and it's not something that even that is taught to doctors or healthcare staff very often. So uh, there is a bit of teaching about LGBT health when you're a medical student or university, but not very much. And what's often there is very stereotypical. So, for example, a couple of years ago, the Royal College of Surgeons ran an exam for surgeons, and one of the questions was, what kind of disease are you most likely to get if you come into contact with the blood of a gay man? And the answer was HIV. So we're still stuck in that stereotype, and that was a national, exam for surgeons, really within the last couple of years. So these things are still going on, and medical education has not caught up with where it needs to be yet, and therefore, healthcare staff don't have the knowledge to deal with LGBTQ plus people sensitively or effectively. We don't have confidence in doing it. That leads to patients having a poor experience when they come to see their doctor. It leads to missed opportunities to promote their health, like that cervical screening, and it leads to people not wanting to come and disengaging with their health services as well. Transgender people I've put on a different slide because unfortunately they are also much more likely to experience health inequalities. And I won't read through all of these, but some of these statistics are really quite shocking. So the very high rates of mental health problems, the very high rates of considering or attempting suicide, the very high rates of domestic abuse are really, really concerning compared to the general population, in which the rates are much lower. So up to 25% of the general population may experience some kind of mental health problem in their lifetime, and that's compared to 66% of clinically significant anxiety or depression in the trans community. So it's important to remember, as I said, that being transgender itself is not a mental health problem. So this is not because people are transgender that they get these problems. It's because they exist in a society that discriminates against them and doesn't understand them and isolates them and doesn't provide them with the medical care that they need. So thinking about that then, thinking about what medical care people need and what's going on at the moment, I won't spend too long on this, but we'll sort of give you an idea of what healthcare is available for gender diverse people at the moment. So around the country, there are gender identity clinics. There's about 8 of them for adults. So if you go along to your doctor and say you think you might be you're not quite sure about your gender identity, you think it might be different from the sex you're assigned at birth, you wonder if you might be transgender, or you are, then you are referred off to a gender identity clinic. And then when you get to that clinic, you're sort of thoroughly assessed by a variety of health professionals for mental health, physical health, and you can either access, if you want to, hormone therapy or surgery to change your physical appearance to align your your sort of physical appearance to your gender identity. Not everyone wants to do that. Not everyone wants to have treatment. Not everyone has every type of treatment. It's very an individual decision, and it's a sort of process that takes a good couple of years for people to sort of go through that whole assessment process. If you're under 18, then you used to be referred to one clinic in central London, which dealt with all of the cases in the country. And that was really sort of overwhelmed by the number of cases that they had. So in 2009, there were about 97 referrals to the service. And in 2022, there are over 3,500. So a huge increase in the number of people were being referred, but not really an increase in the funding or the capacity or the resources that clinic had to deal with them. And essentially that led to the sort of standards of care falling and problems in terms of following people up appropriately or collecting data and information about the impact of the treatments and what was going on. So it became a bit controversial, and it's going to close at the end of next month. And instead, there's a review going on at the moment called the CAST review, which is designing a new service for under 18s, which is going to look a lot more like the adult service, where there's regional clinics around the country, and a lot greater focus on psychological support and mental well-being while people are being treated. The impact of all of this is on waiting times. So as I said, there's been a huge increase in referrals over the last few years, and the average waiting time for an adult gender identity clinic is 5 to 7 years as of 2023. So people are waiting an extremely long time to access care. The national NHS target for waiting times is 18 weeks. That's the legal limit for which you should be seen. And obviously, after COVID and the pandemic, that's not being met for a whole variety of clinical specialties because everywhere is under such pressure. But it's particularly bad in gender services. Things are a little bit better in Wales when the service has already been redesigned in Wales and the waiting lists are a bit shorter, perhaps around 18 months, but it's still a lot longer than it should be. And the problem with waiting times is that it's distressing. And there's not really very much that people can do about it in the meantime. And we think now that while the new service for under 18s is being set up, they're not accepting any referrals. So you email off a referral and it just sits in an email inbox indefinitely until someone decides that now they're going to start looking at them. So we don't know when the new service is going to start. We don't know when under 18s are going to be able to start receiving care again. And current estimates are that if you're referred by your doctor now to a gender service, it will take over 20 years from that referral to you being able to complete the treatment pathway. So it's an extremely long time. And if you're a person who feels like they are living in the wrong body, essentially, or you're living in a gender role which isn't what you want to do, then that can be very distressing. Your entire life is on hold, and it contributes, unfortunately, to poor mental health in a lot of people who are waiting for treatment. And that was 60% of people on the waiting list feel that their waiting time contributes to their poor mental health, and sometimes to suicide as well. That was illustrated in the case of Alice Littman last year, who was a 20-year-old trans woman who committed suicide after waiting 3 years on the waiting list for treatment. And the inquest into her death found that the waiting time, but also crucially the lack of mental health support while she was waiting for treatment, was a factor in her death. So it's a real problem that doesn't yet have a solution, but is having a real life impact, a serious impact on people's well-being in the meantime. So that's quite challenging, as is some of the conversation about health policy that's going on at the moment. So some of the political tone of what's going on is not particularly positive for trans people. Obviously, I'm not going to get into politics, not a political organisation, and we don't really have a political affiliation. But for instance, the previous health secretary, not the one we've got at the moment, but the previous one, said last year that he would be changing the rules of the NHS so that transgender people had to be accommodated in hospital wards with other people based on the sex they're assigned at birth, not their gender identity. So someone who was assigned female at birth but transitioned to being a man would have to go and be in a ward with other women instead of men, and vice versa. And that was based on the idea that there was some sort of threat from transgender people to everybody else. But actually, there was some research that was done in 2022 where every hospital in the country was contacted, and no single hospital anywhere in the country had any complaints whatsoever about transgender people being housed on the ward appropriate to their gender identity. So there was this big political hoo-ha about it, but actually no evidence that it was even a problem in the first place. So that is an illustration really of the atmosphere which has been created around transgender people, which really is completely unnecessary. And similar things going on in the legal world as well. So the process by which people change their legal gender is undergoing review. There's been some changes you may have heard about in Scotland in the last couple of years, or changes that were proposed and voted through by the Scottish Parliament, but was subsequently blocked by the Westminster government. So there's a lot of things going on at the moment in the wider world which make it a very uncertain time for transgender people, a very worrying time for transgender people. They don't know what their rights are, they don't know if they're going to change, they don't know what their access to healthcare is going to be in the future, they don't know how long they're going to have to wait for healthcare or what impact that's going to have on the rest of their life being on hold in the meantime. So it is quite a challenging position for people to be in at the moment, and I think it's important for us all to recognise that. That feeds into people's experiences of healthcare. So a third of men and a half of women have had a negative experience of healthcare. This is of LGBTQ plus people. People feel inappropriate comments are made about them. People feel even pressured into questioning their sexual orientation when they come and see their NHS staff, which is quite concerning. But the most worrying statistics here are the ones on the bottom of the slide, in that so many people don't come out to their GP, don't tell their GP about their sexual orientation or gender identity, which is a real problem in that we then can't offer them good quality care that's tailored to their individual needs if we don't fully understand them. And that so many people, 70% of trans people, have avoided treatment because they fear they're going to be discriminated against when they come and ask for help is an absolute disaster. Because if people don't come and see us, then we can't possibly look after them. We can't possibly offer them good quality care, including care that is about health promotion and preventing ill health as well. So it's not just about treating disease, it's about preventing disease in the first place and keeping people healthy in the long term. So we can't do any of that if they don't come and see us. And what about working in the NHS today? I said it wasn't all as good as it could be. So this is a survey done by GLAD and the BMA, the British Medical Association, in 2022. And it showed that significant proportion of LGBTQ plus staff, so, you know, doctors, dentists, medical students, dental students, don't come out at work and they're not themselves at work. A significant proportion of people experience discrimination at work, but also a large number of, so 70% of people who experience discrimination, but also 80% of people who witness it, whether they're LGBTQ plus or not, don't feel able to report discrimination. So they don't speak up and do anything about it. And that's either because they don't know how to, they don't think it's serious, they don't have confidence that anything's going to be done about it, but also because a lot of the discrimination that takes place is quite sort of low level. So it's not people going up and, I mean, that does happen, people, you know, abused verbally and physically, but a lot of it is about jokes and banter and sort of low level stuff that sneaks under the radar and people don't really know what to do anything about. So it makes it quite difficult to know how to report it sometimes, unless we take a more robust organisational approach as the NHS to say this isn't acceptable and this is what needs to be done about it. And another really interesting thing that came out of this study was that the majority of LGBTQ plus people feel homophobia or biphobia or transphobia is an issue in the medical profession. And that's only compared to 26% of their heterosexual colleagues. And only 6% of heterosexual people thought transphobia was an issue. So it's a problem for people who are experiencing it. It's a problem for the LGBTQ plus community, but other people aren't aware of it and they don't know what's going on. They don't think it's a problem. And that puts up a real barrier in terms of changing things from a wider organisational perspective if the wider population don't see it as an issue. And there's some quotes here on the right, which I'll leave you to read, which sort of gives an idea as to why people don't feel able to come out at work. And there's that feeling of being isolated from their colleagues, not being part of the team, not being one of the, you know, the gang, and not wanting to admit that you have a problem because you're seen as, oh, you're the LGBTQ plus person, you have to take all of this responsibility for, for being an effective person, a good person, being good at your job and not having a hard time because you're this sort of flagship person for the community. So how does that fit in with GLAD then and what we do? So we are, as I say, the UK's Association of LGBTQ plus doctors and dentists. So we are a support network for LGBTQ plus doctors and dentists. And we also provide a lot of support to students as well as they're coming through university. We do a lot of work in educating people on LGBTQ plus health issues. We support research into LGBTQ plus health. We run a mentoring program. But we also do a lot of work on policy as well. So we sit as part of the Equality and Diversity Committees for the General Medical Council and the British Medical Association. We work quite closely with the Office of the National Advisor for LGBT Health, and we also have initiatives like tackling conversion therapy through a charter for medical schools to combat it, and also lobbying the government as well to bring in a ban on conversion therapy as soon as possible. And announced this morning is quite an exciting piece of work we've collaborated with the General Medical Council on, where the General Medical Council has issued a public apology for the first time to doctors who were investigated and had their license to practice removed because of their homosexuality. So that happened to a number of people throughout history. We don't know how many really, but there's a number of cases that have been identified of people losing their jobs and their careers because of being LGBTQ+. And this is the first time that the regulator has apologised for that historically. So that's a really significant moment and a really significant piece of work that's been announced today. So we're very proud of that as well. So coming to the end now, we've thought a lot about what's been going on in the history and what that means for people now. But what can you do, whether you're LGBTQ+ or not, whether you work in the health service or not? What can you do to improve the lives of LGBTQ+ people in your community? And really, the first thing is that be interested in what's going on for LGBTQ+ people. Hopefully by attending this talk you are, but be interested and be thoughtful in your allyship. So what you think LGBTQ+ people need isn't always what they do need. So if you want to try and make a difference, understand from LGBTQ+ people what the issues facing them are, be that at work, in your own workplace, be it at home, be it in your communities. The responsibility for change shouldn't always fall on the shoulders of LGBTQ+ people. They shouldn't always be the ones having to put their hand up and say, well, this isn't right for me, this isn't good enough, this is a problem. It should be the responsibility of everybody to be looking out for each other and noticing what needs to change. Some of the easy things that you can do to start to be more inclusive to LGBTQ+ people, to be an ally, is to think a little bit about the language that you use. So don't assume that somebody's got a husband or a wife or a boyfriend or a girlfriend. Do they have a partner? Don't assume that somebody is going to be Mr. or Mrs. just because they look like a man or a woman. They may not be. They may have a different gender identity. So it's just about thinking about being inclusive and not making assumptions about people. Sharing your pronouns. This may be something you've come across, particularly in a work setting. On bottom of all my emails, I say sign off by saying Kit Tigwell, he, him, because I would be approached by people talking about me as he or him, and you can put she or her if you identify as female, or if you don't identify as male or female or something in between, you can always put they or them instead, and that's something quite an easy way of being inclusive, even if you don't feel that your pronouns are particularly different to what you'd expect them to be. It's a nice way to open up that conversation for other people. And crucially, as I said, we've seen that there's a problem with reporting unacceptable behaviour in the health service, but in life generally, often people don't step in and do something about behaviour that they don't like or they don't think is appropriate. So if you see someone being discriminated against, even if it's only a very low level thing, don't be afraid to challenge that behaviour and call someone out on it, because that can make a real difference to the person who's experiencing it. There's some resources here for you if you want to find out a little bit more about it, both LGBT issues more generally, but also LGBT health, particularly if you are LGBTQ+ and you're watching this and you want a bit more support for your health or health issues, then there's a lot here for you, and both also for family and friends as well. And I think these are going to be sent round separately, so you'll be able to click on the links and follow them separately as well. So that's sort of come to the end of my talk, really. If you want to find out a little bit more about GLAD, what we do, then there's our website and our social media handle. I'll come to some comments and questions if there are any in a moment, but just sum up by saying, sort of reiterating that health services are still really not now set up to be accessible to LGBTQ+ people, or to meet the needs of LGBTQ+ people who throughout history have been pathologized or ignored by health services. And now that leads to a distrust often from the community, which contributes to those health inequalities. So this month is really important. The theme of this month is really important to encourage health services to reflect on, yes, we've come far, but actually there's still much further to go. What could we be doing differently? And what do we, what do we need to do now to allow LGBTQ plus people to feel safe and confident coming to see their doctor? And what can you do as the general public and as allies to, again, open up the conversation and be inclusive and considered to LGBTQ plus people as well? So let's have a look and see if there are any questions or comments. Okay, so someone has asked, what's my biggest inspiration from LGBTQ plus history? That's a really good question, and there's lots of people to choose from. I'm learning about new people all the time. It's a very good question. I think I struggle to pick out one individual person, really. I think a lot of what I've learned in looking at some of this history is actually, yes, it is often very much down to individuals. So it's down to very motivated or brave individuals to speak out against something and try and bring a change. But very rarely does anyone do this on their own. Usually it is a collaborative thing, working with each other. And only by doing that can you really bring about a change. And I think often, despite it being down to a lot of brave individuals, there's actually it's the actions of ordinary people working together and changing their attitudes that can make the biggest difference. So there's a bit of a cop-out answer there, really. Someone's asked how they can get involved with GLAD. I say you can have a look at our website, glad.co.uk. If you're an LGBTQ plus doctor, dentist, medical or dental student, you're very welcome to join us. And someone's asked, does the NHS provide any form of mental health support or resources for LGBTQ plus healthcare professionals? Yes, they do. So this is often dependent on where you work. So your local hospital or employer will often provide some training on this. There is the national learning resources that you can access through the NHS learning platform nationally. But as I say, a lot of it is down also to third sector groups, charities, some of which I've listed on the resources list for you there. So I'd start there and see how you go. Okie dokie, let me come back to the comments here. Bear with me. So the question here, is neurodivergence more prevalent amongst LGBTQ plus people, and could that be fueling health inequalities? So we don't have very much data about this, so there's not much evidence there. We do know that transgender young people seem to be more likely to have neurodivergent conditions like ADHD or autism. It's not that one causes the other or that they're definitely related, but we seem to see that there's an association there, but we don't really understand it. So yes, neurodivergency can make it more difficult for people to access and engage with health services. So you're right in suggesting that could make it more difficult and fuel health inequalities, but it's not something that we know very much about at the moment. Thank you, Alison, for pointing out some of the waiting times in different services for gender clinics around the country. You're quite right. And then Tarina's asked, as a HR professional, what do you feel is the best way to make an inclusive workplace? So that's a very good question as well. So some of it is about being organizational things. So your organization, do they provide equality and diversity training for their staff? Do they collect data on protected characteristics of staff? So do you know how many LGBTQ plus people work in your organization? Do you collect data on that allows you to know what to do about it? And what's the sort of culture, what's the leadership like in your workplace? So are the leadership open to being progressive and inclusive in their attitudes. But there's also a lot that you can do on an individual basis, which is often, I think, in my experience, often how inclusivity is improved in workplaces is that you have somebody who's very driven and motivated to make a difference. Who maybe you're work in HR, they may work in equality and diversity. In the NHS, every hospital will have an LGBTQ plus staff network. There's often staff, chaired by somebody who's very enthusiastic and trying to make a difference on their own. But it is often, unfortunately, very much down to personality and individuals to make a difference. So being open and interested in the topic as you are is a fantastic place to start. But I think about what can you do to understand your population, what can you do to understand LGBTQ plus people in your workplace, and also what can you do to sort of signify an open and welcoming environment. So it's a lot of it, this is about visibility. If you start with visibility, a lot of other things will follow. So do you celebrate LGBT History Month in your workplace? Do you celebrate Pride season? Do you encourage staff to wear rainbow lanyards, or do you put pronouns in your email signatures, as I was talking about? These things start to sort of introduce the wider workforce to LGBTQ plus issues. So there's lots you can do from organisational things, but there's lots you can do as a motivated individual as well. And I don't know very much about it, but I believe that there are organisations out there from a HR point of view and training for HR people about LGBTQ plus issues. So it might be worth having a little look at that as well. Julie's popped in a question. Is there a role for medical schools and the next generation of medical students to change inequalities in healthcare? Absolutely. That's really where we need to be focusing, is changing people's attitudes as they come through and making them more aware of things as they come through. And a lot of work that has been going on in the last few years from GLAD and from universities is to try and embed LGBTQ plus issues into the curriculum for medical students, so that they get teaching on the issues, they're aware of the issues, and therefore they can both know how to approach LGBTQ plus people and treat them properly, but they also have an interest in tackling health inequalities. Because that's a big thing that all of us who work in healthcare are really passionate about doing. We want to improve people's lives, we want to make people better, we want to improve our communities, and we just need to know more about it to start with. So medical schools are a really big key thing, and it's encouraging that a lot of work is going on at the moment to try and improve people's awareness of it right from the beginning of their careers. I think that might be our last question. Brilliant. Well, if there's no others, then we might wrap up there. If you do have any other questions, particularly burning ones, you can always contact us at GLAD, and we'll be happy to answer them for you. But it's been a real pleasure to speak to you all this morning. Thank you very much for joining me, and I hope you enjoy the rest of the events for LGBT History Month this year.